Hello everybody, this is Dr. Patel. I'm an assistant professor of medicine. Today we are going to talk about arterial blood gas and acid-base disorders. This first part is going to cover arterial blood gas analysis. The target audience for this lecture is fourth year medical student. Let's dive into it. Like in all procedures, first of all, you would like to get a consent, and then pre-procedure checklist consists of performing Allen test. Then you need to select the side. You can choose any artery. The most commonly chosen arteries are femoral artery and radial artery. After you are done with the procedures, you are supposed to hold pressure. Make sure that hemostasis has been achieved. And then after you are done with the procedure, you are supposed to document the procedures. Let's talk about Allen's test. This test is performed to make sure that the radial artery that you are going to puncture is not an end artery. So to perform this test, you ask your patient to clench their fist and you provide firm external pressure with your two fingers, and you wait for a few seconds until the hand is completely blanched. Then you ask your patient to open their fist to make sure that the whole hand is completely blanched. And when that happens, you would like to release the pressure in one of the artery. So typically you start with the radial artery. When you release that pressure on the radial artery, the collar should return within 15 seconds. Sometimes there is no connection between radial system and ulnar system. In that case, the ulnar half of the palm remains blanched. So that means the radial artery is an end artery and you cannot puncture radial artery in that circumstances. You would like to repeat that test similarly on the ulnar side to make sure that you perform this test on the both arteries. Alright, so after post-draw, there are a few things you need to take into consideration. You may want to transfer that sample as soon as possible because you don't want WBC to consume the oxygen that is actually contained in that sample. So that phenomenon, we call it leukocytal arsency. So, and that can actually result in low partial pressure of oxygen. So it's most pronounced, this effect is most pronounced in people who have a high WBC count, somebody with leukemia. Sources of error. So it's minimal if the sample is placed on the eyes while you transport it, and if that sample is analyzed within 15 minutes. Sometimes, you put heparin, acidic heparin, and that can also decrease the pH of that sample. But the whole effect is minimal if you use at least 2 cc of blood. Sometimes presence of air bubbles also can result in falsely high PaO2 and low PaCO2. So you can decrease this error by gently tapping on the syringe to remove the bubbles and analyzing the sample quickly. Do you really need ABG? The answer is no. Because if you look at the pH, PCO2 and bicarbonate from central venous blood, it has reasonable correlation with the arterial pH, arterial PCO2, except in the people who have circulatory failure. So if you compare venous blood to the arterial blood, pH is 0.03 lower than the artery, and PCO2 is 5 to 6 millimeter of mercury higher than arterial. And bicarbonate, lactate, and base deficit, these three numbers are almost equal to arterial bicarbonate. But unfortunately, venous blood gas does not provide, information on patient oxygenation. But in people without circulatory failure, where pulse ox is a reliable indicator or reliable measure to estimate oxygenation, you don't really need ABG. Then who still needs ABG? So the indication of ABG are those people who are grossly hypoxemic, somebody who has ARDS, where the management is dependent upon accurate measurement of PO2, and also people with a poor circulation, somebody with a shock, where pulse oximetry is not useful. Um, Also, in those people where you need to measure PCO2 very accurately, somebody who had a cardiac arrest or somebody who has a neurotrauma, where you are trying to manage permissive hypercapnia, in those circumstances, you need to get ABG. And in case of ERDS and SOG, once you uh, do intubation, once you put them on mechanical ventilation, there, and then you treat them, their circulation tends to get better. So you start with the ABG, then you correlate with end-tidal CO2 and oxygenation of the pulse ox when the circulation improves when you start treatment. So let's start with a typical case. 64-year-old white male admitted with progressive shortness of breath, long-standing history of COPD, is on home oxygen. Um, while in the hospital, he develops episode of worsening shortness of breath, and RRT was called. He has had an ABG done, and you're called and asked to review the patient and the ABG. So when they call you for this patient and you are on the way to see this patient, you will think about this patient. So somebody with a COPD. So what do you expect on this patient's ABG? So I would definitely expect some hypercarbia in this patient because of long-standing history of COPD. So now ABG result is back. pH is 7.27, PCO2 of 28, PO2 of 52. Bicarbonate is 14. Remember, bicarbonate from ABZ is calculated one. It's not the measured one. So you need to look at bicarbonate from BMP for more accurate measurement. And oxygen saturation of 92. So what is the underlying acid-base process? What would be included in the differential diagnosis of this patient? When should I suspect an acid-base disorder? When you have a patient with unexplained shortness of breath, when there is a marked changes in the fluid or volume status, when there is abnormal bicarbonate, or when there is increase in N gap. So those are the conditions where you are thinking about acid-base disorders. As you all know, pH is a negative logarithm of hydrogen ion concentration. And acidemia is supposed to exist if the pH is below the normal range. On the other hand, alkalemia is supposed to exist if the pH is above the normal range. And what is the normal range? Normal range is from 7.38 to 7.42. Some liberal people, they have the number from 7.35 to 7.45. Both of them are right. Normal carbon dioxide, PCO2, is around 40. And if you look at the range, you can see over here the range extending from 38 to 42. So 38 to 42 is carbon dioxide. And then bicarbonate normal number is 24. And then if you look at the range, it's 22 to 28. And remember, an acidosis or alkalosis may be present even if the pH is in normal range. And if you see on the right side over here, somebody with normal pH of 7.40, they have hydrogen ion concentration of 40. And when pH goes down by 10, hydrogen ion concentration goes up by 10. And then when pH goes up by 10, hydrogen ion goes down by almost 10, by 8. So and these are the different numbers of hydrogen ion concentration with the different pH numbers. Let's talk about PCO2, which is a partial pressure of carbon dioxide. It measures how a patient is ventilating. Remember, respiratory membrane is very much permeable to carbon dioxide. Carbon dioxide is more permeable than oxygen. So anybody who has increase in carbon dioxide, the likely deficit is not in the respiratory membrane, but in the respiratory chain higher up in the system, starting from the brain, phrenic nerve or something in the chest wall, and then it actually reflects the fact that your patient is hyperventilating if there is an increase in PCO2. So the normal number of PCO2 is 40. What about the venous sample and PCO2? So there is a correlation between arterial and venous PCO2. But that has a larger confidence interval from 5.7 to 8.6 based upon different studies that you can see there. But one thing for sure, if you have a venous PCO2 less than 45, it has 100% negative predictive value for hypercarbia. So let's just say you have a patient with COPD and you want to make sure that you are not dealing with hypercarbia. And if they have, let's say, CO2, PCO2 of less than 45 in a venous sample, most likely you are not dealing with hypercarbia. PO2 is partial pressure of oxygen. It's a measure of oxygenation only. Bicarbonate in ABG, it's calculated. It's not measured. So that's why we use BMP bicarbonate, and the normal number is 24. And oxygen saturation useful in determining acuity and severity of individuals' hypoxemia. So base access is kind of obsolete number that many people they don't really use it. But it gives you a little bit information, gross information. So base access, as the name suggests, so there is an excessive base. So patient has a metabolic alkalosis when base access is more than 3 plus. Or they have metabolic acidosis if they have a base access less than -3. So whenever you are writing ABG, you tend to follow this, convention of writing pH first, followed by PCO2, followed by PO2, and then followed by, bicarbonate and oxygen saturation. So let's talk about steps to interpret ABG. You start with identification of primary disorder, whether it's an acidosis or alkalosis. How do you do that? You look at the ABG pH. So we already talked about normal pH range 7.38 to 7.42. But for practical purpose, anybody with pH more than 7.40 has alkalosis. Anybody with pH less than 7.40 has acidosis. So once you know primary disorder, then you identify primary process. How do you do that? So let's say your patient has acidosis and has high carbon dioxide. Most likely it's from the respiratory acidosis. On the other hand, acidosis with low carbon dioxide most likely from metabolic origin. Then you calculate anion gap. How do you calculate anion gap? You first add bicarbonate with chloride and you subtract that number from sodium. Normal anion gap is 12. So sometimes your patient has low albumin number, then you need to make a correction. How do you correct? So let's say your patient has albumin of 2, and then you calculate anion gap 15. So the corrected anion gap in this case is going to be 21. So 1 gram drop of albumin from 4, which is a normal albumin number, 1 gram drop from 4, you add 3 to anion gap. So this patient we just talked about has 2 gram drop from 4. So for 1 gram drop you do 3, you add 3, the second one another 3, so you add 6 to 15, which is 21. So that is a corrected anion gap. Then once you calculate that anion gap, you calculate delta. So delta means how much more anion gap patient has. So that anion gap minus 12 is going to be delta. Why delta is important? Delta has negatively charged. So since delta is negatively charged, it is going to occupy the same compartment occupied by bicarbonate. So with that degree of acidosis, with that degree of delta in the system, the expected bicarbonate is going to be low. So how low? Normal and bicarbonate is 24. 24 minus delta is going to give you the expected bicarbonate for that degree of acidosis. So let's say you calculate expected bicarbonate, and that calculated expected bicarbonate you compare with the BMP bicarbonate, and if that bicarbonate that expected one is more and the patient has less. So let's say the BMP bicarbonate is more than expected bicarbonate, then patient has metabolic alkalosis. If patient's BMP bicarbonate is lower than what you expect, then less bicarbonate is metabolic acidosis. So that's how you calculate metabolic disorders, whether patient has metabolic acidosis or metabolic alkalosis. Once you are done with the metabolic calculation, you calculate respiratory compensation. We calculate expected carbon dioxide by Winter's formula. Winter's formula is bicarbonate into 1.5 plus 8 plus minus 2. So that expected expected carbon dioxide number you compare with ABG carbon dioxide. So let's say ABG carbon dioxide is more than expected carbon dioxide. That means patient has respiratory acidosis. On the other hand, if the ABG carbon dioxide is less than expected carbon dioxide, that means patient has respiratory alkalosis. Once you do this metabolic calculation and respiratory calculation, you know what disorder patient has. Then you try to paint the picture by going over the mnemonics of anion gap acidosis, which is gold mark, and then non-anion gap acidosis, which is hard ups. So you go over each and every of those differentials and try to paint the empty canvas with the information that you have. So let's talk about primary process, respiratory or metabolic. So as you all know, PCO2 normal number is 40, bicarbonate 24. So let's say somebody has acidemia and carbon dioxide is more than 40. Then you know the primary process is respiratory. And let's say if you have acidemia and PCO2 less than 40, the primary process is metabolic. Similarly, if somebody has alkalemia, PCO2 more than 40, it is metabolic. And if somebody has alkalemia and PCO2 less than 40, that means it is respiratory. They are washing off their carbon dioxide. So remember, respiratory compensation is immediate. On the other hand, renal or metabolic compensation takes time. It lags behind by almost 6 to 12 hours for onset, and it requires almost 1 to 2 days for reaching steady state. So somebody with metabolic alkalosis, it's compensated with hyperventilation, but it cannot result in PCO2 of 55 or beyond without causing respiratory arrest. Similarly, if somebody has a metabolic acidosis, you compensate with hyperventilation, but that hyperventilation is not good enough to bring that PCO2 below 12. So remember that. So, and then primary process are never completely compensated. They're only partially compensated. Since they're only partially compensated, you have always some clue to the diagnosis of primary process when you look at the pH. And then compensation can not do total correction. Remember that. Except in the case of chronic respiratory alkalosis, that's the only primary disorder where compensation can actually result in the normal pH. Remember, general rule of thumb, you cannot overcompensate. Let's talk about compensation. So I have put all the formula that you are supposed to know for acid-base calculation in this one slide. So make sure you use this slide for your future reference or any calculation that you are going to do in the future. And all the example acid-base cases that I'm going to give it to you, make sure you are going to apply all this compensation formula. All right. So we already talked about metabolic acidosis expected by PCO2. So let's talk a little bit about respiratory compensation. So in respiratory acidosis, whenever carbon dioxide goes up, let's say by 10, pH is supposed to go down by, you multiply this 0.08 with 10, right? So that is going to be 0.08. So if somebody has a PCO2 of 50, which is 10 above the normal, pH is supposed to go down by 0.08 if it is acute. If it is chronic, let's say COPDers, if they have a PCO2 of 50, it is supposed to go down by 0.03. You have to multiply 10 because this is for 1. So that means pH is supposed to go down up to 7.37. All right, so there are 4 different kinds of respiratory failure. Type 1 is called hypoxemic respiratory failure, where the oxygen number is down. Type 2 is not only oxygen down, they also have high carbon dioxide. So remember, carbon dioxide is very much permeable. So if somebody has problem with carbon dioxide retention, most likely the disease is not in the respiratory membrane. It's somewhere higher up. Then third type, type 3 is a subset of type 1 failure, but it tends to occur in the perioperative setting. And then type 4 is with somebody who has a shock. In respiratory failure, type 2 respiratory failure, where you see respiratory acidosis, if you treat the underlying cause, you are going to fix that respiratory acidosis as soon as you put that patient on mechanical ventilation. The correction is very much easier, which is in contrast to type 1 respiratory failure, which is rather a little bit difficult to treat, because in type 1 respiratory failure they are hypoxic, and then when they are hypoxic there are 5 causes of hypoxemia that I'm going to talk about. So you need to look into those hypoxic causes, and you need to actually correct those causes of hypoxemia before your patient gets better. On the other hand, the problem with type 2 is ventilatory deficit, which is immediately corrected as soon as you put them on ventilation. So let's talk about type 1 respiratory failure, and indications of oxygen. So at rest, when you do pulse ox and then pulse ox number is 88 or less, or if you do ABG and the ABG number is 55 or less, people qualify for oxygen. So those are the indication for oxygen. So sometimes people are chronically hypoxic and they have a feature of chronic hypoxemia. So remember, low oxygen concentration in the pulmonary circulation causes pulmonary hypertension, which is completely in contrast to systemic circulation where low oxygen or high carbon dioxide results in vasodilation. So in the pulmonary circulation, it causes pulmonary hypertension. And if somebody has pulmonary hypertension for some time, they tend to get feature like pedal edema or dependent edema. And they also have P pulmonale in the EKG, which is a tall P wave. And also some people they tend to get polycythemia when you check CBC. Polycythemia, which is defined as hematocrit greater than 56%. So when you have this feature, these three feature of chronic hypoxemia, people qualify for oxygen even with the high number of pulse ox. The number we are talking here is 89. Or if you are doing ABG, anybody with a PO2 less than 60. So the number we are talking here is 56, 57, 58, and 59. So if somebody has feature of chronic hypoxemia, they qualify for oxygen even with higher numbers, which is 56 to 59. Sometimes people drop their PO2 with exercise as long as their hypoxemia improve with oxygen supplementation. They qualify for oxygen. And for sleep, if you have a patient whose arterial PO2 is below 55, they will qualify for oxygen. Or if you're doing pulse ox, it has to be 88 or less, but it has to be persistent. Just one number is not adequate. It has to be for at least 5 minutes for them to qualify for oxygen. And as we already talked, if somebody has a feature of chronic hypoxemia, like pedal edema, P pulmonale, or polycythemia, the number in these folks becomes 89 rather than 88 of pulse ox. And similarly, PO2 becomes 59 or less for qualification of oxygen. So talking about respiratory chain, it starts from central nervous system, then goes down the peripheral nerves, and then respiratory muscles and rib cage. So these first three of this chain kind of constitute something we call ventilatory apparatus. So basically, somebody, who have a trouble with these three ring of this chain, results in increase in carbon dioxide. On the other hand, if somebody has trouble with the next two, which is upper and lower airway and lung and parenchyma, upper and lower airway with asthma, with COPD, or somebody with a lung parenchyma, pneumonia, those are the people who tend to get type 1 respiratory failure. In contrast to first three, they tend to get what you call type 2 respiratory failure. And then somebody with a cardiovascular system or low hemoglobin, they also get respiratory failure, which has been classified as a type 4 respiratory failure. One more thing I'd like to talk here is about diaphragmatic paralysis. So remember the root number of diaphragm. So phrenic nerve has a spinal root of 3, 4, 5. So somebody who has a spinal cord trauma above that level, they tend to get diaphragmatic paralysis, and they tend to get type 2 respiratory failure. So first three component, ventilatory pump, and then fourth and fifth basically type 1 respiratory failure. And remember, the last component, that is cardiovascular system and hemoglobin, that constitutes the gas transport system to the tissues. In case of shock or in case of severe anemia, type 4 respiratory failure occurs, that actually, uh, contributed by this component, this last component. So these are the 5 causes of hypoxemia. Start with the VQ mismatch. So the way I remember this is let's just start with with the condition that results in normal EA gradient. So let's talk about that. So let's say if you are in the abrest, high altitude, if you go here, if you are in the abrest, or let's say if you are in the abrest, or if you have taken something, some drug, and you feel like you are in the abrest, those are the two conditions where your EA gradient is going to be normal. Then there are conditions where there is diffusion limitation. So diffusion limitation means there is something wrong in the respiratory membrane, or VQ mismatch. Either there is a disease on the alveolar side, or there is a disease in the blood vessel side that is resulting in VQ mismatch, or they have intracardiac shunt, connection between right and left side of the heart. So these are the 3 conditions where a gradient are increased, and those 2 conditions where people either they are in the abrest with a low oxygen tension, or they have taken something that makes them feel like they are in the abrest. They have taken sedatives. So those are the 2 conditions where a gradient is normal. And with this, I'd like to conclude this session. Thanks for joining. If you have any question, feel free to reach out to me. My email is sbodel@mcw.edu. And thanks for watching.